you, York and Jeff from the PKD Foundation for the invitation. It's unusual to be back in person again. Hopefully we're all okay. So I'll be speaking about basic clinical approaches, and of course these include much of the metabolic and genetic information that you're going to hear about later on. These are my disclosures. So the goals and objectives are shown in this slide. To review the natural history, including renal and extra-renal complications, to review the use of total kidney volume, or TKV, as a prognostic biomarker for ADPKD, and review management goals for general nephrologists, including blood pressure control and ESRD care. So probably everyone in all the lectures has a slide like this, so I'm not going to spend a lot of time on it, but we'll focus on bilateral kidney cysts, progressive decline in GFR, extra-renal manifestations, and if that weren't enough, all of the issues associated with chronic kidney disease, GFR decline. So as has been shown, and you're all very familiar, cysts throughout both kidneys is the hallmark of ADPKD with an inexorable increase in total kidney volume. That's associated with a number of symptoms, including painful and palpable kidneys, progressive loss of kidney function, hypertension, hematuria, cyst infection, nephrolithiasis, and impaired concentrating ability. So this work from the CRISP study reported in the New England Journal of Medicine back in 2006 was a rigorous demonstration of the inexorable expansion of total kidney volume in individuals with ADPKD. Each person is a curve here. The pointer works, but it doesn't show up on the white background, so sorry I can't show you that. But each curve represents an individual, and these are exponential growth curves. And in this initial study by CRISP, GFR declined only in those with a total kidney volume more than 5 times normal. So at least during the 3 years of the CRISP study, GFR did not decline in those with smaller kidneys than the 1,500. This is a slide courtesy of Dr. Tai Bei, and illustrates MRI images of polycystic kidneys. And in the left panel, the T2 weighted images are shown. In the right panel, the T1 weighted images are shown, and these individuals happen to receive gadolinium contrast. The point of this slide is to show in different individuals at different stages of the disease how cyst expansion generally, you can see with each successive stage, the kidneys are larger and there's greater number of cysts to where in the bottom panel, the kidney is almost completely occupied by cysts. And this is evident whether you're using T2 or T1 weighted imaging. We don't typically use gadolinium contrast for routine imaging in ADPKD, but even the non-enhanced T1 weighted images are certainly quite informative. Well, ADPKD is a very expensive proposition for healthcare systems. I'm sorry I don't have a projection of costs in Canada. I just have this study from the US. And note that the average annual cost of ADPKD are highest in the end stage or kidney failure section as compared to other stages. And of course, this reflects the cost of dialysis and transplantation. This includes both direct annual costs of $5.7 billion plus indirect costs of $1.6 billion. And indirect costs include unemployment and decreased productivity as a result of pain and other complications of ADPKD. I hope I don't lose my voice during the presentation, but it is possible. So Terry mentioned the genetics, and York is going to go through them in much greater detail. I think the important thing from a clinical perspective is that PKD2 produces a milder phenotype with later age of diagnosis, later onset of hypertension, smaller kidney volume, fewer kidney cysts, and later age of kidney failure. And this is an old slide, but it illustrates the renal survival of those with PKD1 and PKD2 from a study by Hattaborough from the UK. And the median age of kidney failure for PKD1 was 54. The median age of kidney failure for PKD2 was in the 70s. So clearly a difference. And again, you'll hear more about this from Dr. Pei later on. I think when you're dealing with patients, it's important to keep this pedigree in mind. This is obviously a very large pedigree, but the proband, age 51, with the arrow pointing to her, has affected siblings, an affected parent, affected cousins, affected grandparent, and some nieces and nephews that are also affected. And the children in this particular pedigree haven't been identified yet. So this is part of the human cost of ADPKD, this genetic kidney disease causing kidney failure through multiple generations. So obviously there's a lot of work for us to do. I'll talk briefly about each of the complications in ADPKD, starting with hematuria. Cyst hemorrhage occurs in about 60% of individuals. And this could be gross or microscopic hematuria if the cyst connects to the collecting system, or could reflect intracyst or subcapsular hemorrhage, which doesn't necessarily lead to hematuria. The hematuria results from fragile blood vessels that are stretched across the walls of enlarging cysts, and these are susceptible to minor trauma. Of course, hematuria can be associated with nephrolithiasis and cyst infection also. Patients with recurrent episodes of gross hematuria are thought to have the largest kidneys and may progress more quickly to kidney failure. And at least in individuals with large kidneys, it's important to minimize trauma. Pain is an important manifestation of ADPKD. Affecting approximately 60% of individuals during their lifetime. And we divide pain into different categories. So acute pain can be the result of cyst complications, such as infection, cyst rupture with or without hemorrhage, torsion of the kidney, nephrolithiasis, or even obstruction. And then it's important to point out that abdominal pain could be due to an infection, rupture, or hemorrhage of a hepatic cyst. So just to keep that in mind. Chronic pain results from cyst expansion and enlarging of the kidneys, stretching of the renal capsule, of the kidneys and or of the expansion of the liver compressing adjacent other intra-abdominal structures. And then another component of pain which has been identified as musculoskeletal back pain, which relates to the exaggerated lumbar lordosis due to increased abdominal girth from very large cystic organs. Urinary tract infection is relatively common in ADPKD. It affects up to about half of individuals. It's more common in women than men, and this also includes lower urinary tract infection, such as cystitis. Cyst infection is a characteristic and severe infection with fever, flank, or abdominal pain, malaise, and other constitutional symptoms. So the finding of a positive blood culture in the absence of a positive urine culture is strongly suggestive of a cyst infection rather than pyelonephritis. Treating of a cyst infection typically requires a prolonged course of antibiotics, and ideally we would use lipophilic antibiotics. We actually don't have a lot of direct information on some of the newer antibiotics which may be necessary in the presence of antibiotic resistance. Cyst drainage is not always necessary, and this would be in the case of refractory infection. Localization of an infected cyst may be difficult. I mean, if you have a very large cyst with thick walls, that may be the obvious cyst to drain if you have to drain. Otherwise, PET-CT scan would be utilized to try and identify the cyst for drainage. Quality of life issues are very important. And if we listen to our patients, they'll tell us about these. And sometimes in the rush of a typical outpatient visit that these don't get covered well. But large cystic organs adversely impact the quality of life. And enlargement of the kidneys and or the liver in some patients results in substantial enlargement of the abdomen, chronic pain and discomfort, and in many people, concerns about body image. In middle age, as the kidneys and liver go, the belly gets bigger. People say, well, I'm going to the gym, I'm working out. You're not fat, it's your enlarged organs. Large kidneys and or liver could impair motion of the diaphragm, possibly causing a sleep disturbance. And of course, seat belts could cause increased kidney pain. This is a collection of large bellies and kidneys shared with me some years ago by Jared Grantham. These are obviously truly remarkably large kidneys, and they don't have to be this large to cause trouble. So we typically use ultrasound to diagnose ADPKD, although MRI or CT imaging are much more informative. So these are diagnostic criteria that Dr. Pei has had a major role in implementing. So in a PKD1 family, if in an individual under the age of 30, at least 2 cysts in either or both kidneys, ages 30 to 55, 2 cysts per kidney, and age greater than 60, at least 4 cysts per kidney. And Dr. Pei and colleagues have nicely sorted out what you do with families of unknown genotype, which is more often than not when we encounter people in the clinic. I should mention, even if you don't have genotype, if you have at least one family member with kidney failure, that would be suggestive of a PKD1 mutation. So you can see the criteria are slightly different. So the age group, the initial group, goes from 15 to 39 and requires at least 3 cysts in either or both kidneys. Age 40 to 59, at least 2 cysts per kidney. So remember, that expanded from 30 to 59 and those with a definitive PKD1 mutation. And age greater than 60 is the same, at least 4 cysts per kidney. And if you're 40 or older and you have fewer than 2 cysts, that has a good negative predictive value. I'm going to spend time talking about the Mayo imaging classification, which is based on total kidney volume, and this is a way of assessing prognosis in ADPKD. So the graph shows a cross-section of individuals at different ages with on the x-axis and height-corrected total kidney volume on the y-axis. And the way to think about this is if you're a young person with large kidneys, it means that your kidneys grew at a faster rate. Whereas if you're a young person with small kidneys, your kidneys grew at a slower rate. And similarly, if you're an older person with small kidneys, your kidneys didn't grow that much over time. And based on this criterion, these individuals were divided into classes, which is, and class 1 requires a diffuse distribution of cysts throughout the kidney parenchyma. So this is what we call typical ADPKD. Atypical ADPKD would be unilateral disease or focal disease, or where very large cysts dominate the kidney. So when you classify people according to their height-corrected kidney volume at age, you're able to ascertain a rate of progression that would apply in general to that group of patients. So class 1A and 1B have a much slower rate of progression, either for males or females, where classes 1C, 1D, and 1E have a much faster rate of, this is GFR decline. So going from this classification of height-corrected kidney volume per age, it's possible to ascertain a prediction of what future GFR decline would be. And those with class 1D and 1E have the fastest rates of decline of kidney function. And these models have been further validated by Alan Yu and the CRISP cohort by applying them to the cohort of patients who participated in the whole PKD patient study. So more than 500 individuals with total kidney volumes progressively. And you can see in class 1A, there's a very little decline of kidney function, whereas in class E, you can see that there's almost no period of normal and stable kidney function, at least in young adults and onward. So the use of the Mayo imaging classification to understand total kidney volume is very important in our approach to management. And to me, it's fundamental because it assesses the prognosis or the risk of progression, and that helps you target your treatments. So we'll go through a few cases. Case one is a young female, newly diagnosed without hypertension, reasonably well-preserved GFR. The family history is shown there. It's a positive family history. And she had polyuria and enuresis as her presenting symptoms. So this approach is one that I would suggest we use for all individuals. And we start off with the diagnosis of ADPKD, confirming whether it's typical, as shown in the left, with bilateral and diffuse cyst distribution versus atypical. Measure total kidney volume using CT or MRI, and then classify them using the Mayo classification. And there's a relatively easy way to estimate kidney volume that you can teach your radiologist, or you can either use yourself using the ellipsoid equation. So if individuals have Mayo classes 1C, D, or 1 or E, shown in the orange box on the left, that's the definition of rapidly progressive ADPKD, and these individuals would become eligible for tolvaptan or potentially for other more advanced therapies as they're developed. If, on the other hand, they're Mayo 1A or 1B, or they have atypical ADPKD, we would implement all these general management measures. And I'll go through each of these in detail so that everyone with ADPKD should have optimal general management measures implemented. So this is the ultrasound and the MRI of this young woman. She ended up being Mayo class 1B, and you can see the dramatic difference between the MRI on the right and the ultrasound on the left. You can pick up many small cysts in the T2 weighted MRI, and it's much easier to estimate kidney volume. So based on this, she would not normally be considered a candidate for tolvaptan therapy, which Dr. Torres will talk about in more detail. So the optimal management of ADPKD includes enhanced hydration, moderate sodium restriction, maintaining normal BMI and a moderate caloric restriction, lipid control, and blood pressure control. And I'll go through each of these in more detail. So as shown by Terry, and you'll hear about more later, if you block or suppress vasopressin, this has a marked effect on cystogenesis in preclinical models. And in the left panel, those animal models were treated with a vasopressin receptor blocker. On the top right panel, the rats were encouraged to vigorously hydrate by putting sugar in the water. And in this particular model, the increased hydration had an impact on slowing cystogenesis, comparing this to that. It's important that the hydration be looked at in a model with distal tubular collecting duct origin of cyst. For example, it shouldn't work in a proximal tubular model of cyst. And finally, as Terry showed you, when you cross Brattleboro rats that lack vasopressin with these PCK rats, which have polycystic disease, when you have the PCK gene and no vasopressin, in the middle here, the rat's kidneys are virtually normal, and when you administer vasopressin in the form of DDAVP, you accentuate the disease. I think this is a compelling evidence of the role of vasopressin. So the treatment goals of high water intake would be to reduce urine osmolality below 280 or to substantially decrease urine osmolality by at least 300. This requires at least 3 liters of water per day. Recall that urine output is also affected by solute intake. So if you have a large solute load of that is salt and protein, that will increase your urine output and the fluid requirement. You avoid high water intake in individuals at risk of hyponatremia. Dr. Torres will review a recently published large clinical trial called Prevent PKD, which did not show a benefit of high water intake, but only about half of the individuals met the urine osmolarity goals. So he'll explain more about the relevance of this to clinical practice. Dietary sodium. Salt is poison for ADPKD. For the sake of time, I won't go through each aspect of this slide in great detail, but suffice it to say that in both the CRISP and the HALT study, average dietary sodium was too high. And the higher the sodium, it correlated with worse outcomes, either GFR progression or total kidney volume increase. And the impact of counseling in patients followed in expert academic medical centers in both CRISP and HALT was limited. So that's another area of how do people maintain a dietary change for their lifetime. And Dr. Weems will also talk about that in relationship to other components of the diet. Obesity is bad for you. And again, this is related to the metabolic defects that Terry went over so nicely. So HALT PKD study A, where GFR was greater than 60, overweight and obesity were associated with faster TKV growth and eGFR slope decline. So that's shown in the gray and the black bars. These were significantly different than for normal individuals. So in rodent models, mild to moderate caloric restriction or ketogenic diet decreases cystogenesis. And again, Dr. Weems will talk about this in great detail tomorrow. Not so long ago, actually it's about 9 months now, the group from Colorado published the results of a pilot study in 28 participants who were randomized to either dietary caloric restriction of about 1,700 calories per day versus intermittent fasting, where the fast day 3 times a week was associated with a caloric intake of 532 calories. And the dietary caloric restriction is shown in the orange circles. Intermittent fasting is shown in the blue circles. And in the graph on the left, it demonstrates that the greater the decrease in weight, the greater the reduction in total kidney volume growth over the 1-year period of this pilot study. And then if you break down the patients into those that lost less than 5% or more than 5% body mass, you could see those that lost more than 5% actually on average had no growth in their kidney volume over 1 year. And this is a fairly extraordinary result. It's the kind of thing you see in preclinical models. And whether this can be sustained over time is important. But, you know, there's a lot of good reasons for most people to maintain or lose weight. Prevention of diabetes, cardiovascular health, general health. It's easier on your joints as you go older. So a safe loss of weight is certainly something that we could encourage without having massive, expensive clinical trials. So this is the second case. Not sure how I'm doing time-wise, York, but 5 minutes, okay. I'll try to speed up. This woman has hypertension. She has large kidneys, reduced GFR. She's Mayo class 1C. I'll use this to talk about hypertension. We believe that hypertension in ADPKD is due to activation of the renin-angiotensin-aldosterone system with bilateral kidney cysts, compressing arterioles. This results in an increase in A2 and downstream events of increased aldosterone, increased renal sodium retention, and increased vascular resistance, resulting in hypertension. In addition, the downstream effects of angiotensin II on fibrosis and mitogenesis are very important. So the HALT PKD study had two groups. Study A was with individuals who were ages 18 to 50 with an eGFR greater than 60. And in HALT PKD study A, the effect of angiotensin RAS blocker was compared to the effect of a RAS blocker plus an angiotensin receptor antagonist. So lisinopril versus lisinopril plus telmisartan or placebo. And there was no benefit of the combined ACE-ARB therapy. I'll just state that at the outset. But the intensive blood pressure arm had a slower rate of kidney volume growth over 5 years, reduced left ventricular mass index, reduced proteinuria, and reduced renal vascular resistance with a borderline impact on slowing GFR progression. Study B, there was no benefit of combined ACE or ARB. There was no intensive blood pressure arm in study B. And then the preferred order of treatment for hypertension ADPKD is to start off with ACE-ARB and then move on through either a cardioselective beta blocker, a calcium channel blocker, and you'll note that diuretic is way down the list. So this is an individual more severely advanced with hypertension. You can see in this contrast CT scan, very little parenchyma and areas of cyst hemorrhage. This individual had a nephrectomy because of intolerable pain, and he had it pre-dialysis or pre-transplant, which is kind of unusual. We don't typically do that. As mentioned, Dr. Torres will talk more about tolvaptan. I've just shown the US and the Canadian indications here. They differ slightly. In Canada, tolvaptan is indicated to slow the progression of kidney enlargement and kidney function decline. In the US, it's only indicated to slow kidney function decline. And Dr. Torres will talk more about that later on. So this is a young woman with who presented with abdominal pain and had a very substantially enlarged cystic liver, as shown on this particular slide. So this is one of the extra-renal manifestations of ADPKD that we worry about. So hepatic and pancreatic cysts are asymptomatic in many patients, can expand and cause pain, abdominal distension, infection. PLD is typically worse in females. It seems to be made worse by additional estrogens, such as through more pregnancies or postmenopausal hormone replacement, and very rarely massive PLD. So we avoid exogenous estrogens, and in some individuals consider somatostatin for severe PLD. Cardiac valvular abnormalities, mitral tricuspid and aortic prolapse, regurgitation, dilated cardiomyopathy. Seminal vesicle cysts are very common. They're not generally thought to be associated with infertility, but they're found when you investigate men. This is an example of massive polycystic liver disease. Brain aneurysms, very important. Risk of rupture depends on size and location. We know that smoking, uncontrolled hypertension, and excessive alcohol use increase the rupture rate. They're found in approximately 5% of patients without a family history and about 22% of patients who do have a family history of aneurysm or subarachnoid hemorrhage. And typically we screen those with a positive family history and certain occupations. And I think we've become more accepting of people who request screening because they find it intolerable not to know. But of course, recognize if you find an aneurysm, that leads you to a path of either monitoring or observation, potentially angiography with subsequent complications. And typically these are diagnosed on non-contrast magnetic resonance angiography. So optimal management in CKD4, optimize cardiovascular and overall health, prepare for kidney replacement therapy, manage complications, and the preferred modality for end-stage kidney disease would be preemptive live donor transplant and appropriate preparation and anticipation of such, for example, such as weight loss. And certainly looking for a living donor and possibly from the extended family. Just a few more slides, Jörg. So we know that survival with after kidney failure is better than the general kidney failure population. Even when you exclude diabetics from the control group, it's still better than the controls. PD is successful in ADPKD. There are issues such as hernias, large kidney cysts and liver diverticulitis, but it should not be routinely ruled out as a potential therapy in ADPKD. On HD, we of course are concerned about anticoagulation and cyst bleeds. And we know that the mortality from extra-renal issues is far less than that due to cardiovascular disease. So again, anything you can do to make the heart healthy is good. Transplant outcomes are similar to other groups. So I showed you a patient who had nephrectomy for severe pain. These would be the other indications for pre-transplant nephrectomy, which could in some people put them on dialysis. So recurrent and or severe infection, a large staghorn calculus, recurrent and or severe bleeding, I mentioned pain, suspicion of renal cancer, and then space restrictions, taking into account that kidney size typically declines after transplant. And if a kidney was removed for space, it should only be the ipsilateral kidney. You don't need to remove both kidneys for space. How do you remove these kidneys? Well, you could do simultaneous transplant and bilateral native nephrectomy. This requires an experienced surgical team. This should not be done willy-nilly at a hospital without great expertise. So it's a longer and more complicated procedure. It prolongs the cold ischemia time, requires more blood transfusions, but there's no difference in allograft function or survival. And at the end of all this, patients are happier because they only had one procedure. The other approach is the deferred or staged or sandwich nephrectomy. Do the transplant, wait till stabilization of immunosuppression, say 4 to 6 months after transplant, but it requires an additional surgery, which would typically be a hand-assisted laparoscopic surgery. These are two studies that demonstrate the 20 or 30% decrease in total kidney volume by 1 year after transplant. So patients may benefit from this and may not need their kidneys out at all. It's just something to factor in. So summary, lots of supportive data to support blood pressure, dietary, and lifestyle interventions to improve kidney and cardiovascular outcomes. Methods to establish risk of rapid progression are established, and there's one approved agent and many others in the pipeline. Thanks for your attention. I have the quizzes here. I can read them, but I'm not. I think you have to go to the.
I think people can download the app for the entry of their answer,
Yeah.
but I think probably this is the best way is to read it.
Okay.
Yeah.
So dietary sodium intake should be reduced to A, reduced rate of total kidney volume enlargement. B, decreased likelihood of nephrolithiasis. C, improved blood pressure control. D, lessen the fluid requirement to maintain reduced urine osmolality. Or E, all of the above. So this year I left the answers out of my presentation. So.
Okay.
Looks like we're perfect. Okay, good. Okay, next slide. Maybe the question was too easy. Optimized ADPKD management should be initiated when the GFR is less than 60, only when blood pressure is found to be elevated in all patients. D is when Mayo imaging classification suggests increased risk of progression, that is classes 1C, 1D, and 1E. And last one, when family history demonstrates ESRD below the age of 55. Yep. Very good.